Welcome to today's webinar, Fertility Preservation. My name is Sarah Tarani and I'm the Program Coordinator for Triage Cancer. I'll be moderating today's webinar. Now, before we dive into today's topic, I just need to go over some housekeeping. All callers will be muted for the duration of the webinar. If you have any questions or technical problems, please type them in the chat box to the side of your screen. This webinar is being recorded and will be available for viewing by the end of the week on our website, triagecancer.org. At the end of this webinar, you'll receive an email with a link to a survey. Please take a few moments to fill it out and let us know what you think of today's webinar. We are very grateful for the support of Novartis Pharmaceuticals and the Alliance for Fertility Preservation for sponsoring our 2018 Triage Cancer webinar series. As part of the accreditation process, we have to read the following disclaimers and disclosures to you. Disclaimer. This presentation is intended to provide general information on the topics presented. It is provided with the understanding that the author is not engaged in rendering any legal, medical, or professional services. Although this content was reviewed by professionals, it should not be used as a substitute for professional services. The disclosure. The planners and presenters for this program have not discussed any pertinent financial relationship or conflicts of interest. While this educational program has received commercial support from the previously listed sponsors, the content of the program has no relation to the commercial interest of the organization's product or services. I am pleased to let you know that Triage Cancer is now an accredited provider of continuing nursing education by the American Nurses Credentialing Center's Commission on Accreditation. Therefore, nurses participating in the live webinar may be eligible for 1 contact hour of credit. In order to receive contact hours, you must have registered online for today's session. People who are listening in on someone else's computer will not be eligible for credit. You also must attend the entire webinar. No partial credit will be awarded. Anyone watching a recording of this webinar will also not be eligible for credit. Within 1 week of this webinar, complete an evaluation and post-test. You must receive a passing grade on the post-test to be eligible for contact hours. You will receive an email following this webinar which will contain the link to the evaluation and the post-test. Please note that on the evaluation, it asks for your name and email address. You must include these so that we can certify that you completed the evaluation. That email is the address that we will use to mail your certificates. We'll be sending out those certificates within 4 to 6 weeks. Again, we are only offering contact hours to nurses at this point. If you have any questions or experience any problems, email us at info@triagecancer.org. For those of you who aren't familiar with Triage Cancer, we are a national nonprofit organization that provides education on legal and practical issues that may impact individuals diagnosed with cancer and their caregivers. And we provide this education in a few different ways. First, we host a Speakers Bureau of experts in all types of cancer survivorship issues available to organizations putting on an educational event. You can read our speakers' bios and request a speaker on our website. We not only participate in events all over the country, but we also host our own educational events for patients, survivors, caregivers, advocates, and healthcare professionals. We host the Triage Cancer conferences that are open to patients, survivors, caregivers, and healthcare professionals. We spend the day discussing a variety of cancer survivorship topics. This year's upcoming events will be held in Reno, Nevada, and Lewiston, Maine. Travel assistance is available for patients and survivors to attend these conferences. More information and registration is available on our website. As you know, we host a monthly webinar series. The next one will be on August 15th on pain management. We also record these webinars and you can watch past sessions on our website. We also offer 2 different trainings specifically for healthcare professionals. First, in partnership with Cancer and Careers, we offer a 1-day training called Navigating Cancer, Work, and Insurance. For more information and registration, please visit our website. And the second training that is specific to healthcare professionals is the Insurance and Finance Intensive. This is a comprehensive certificate program for oncology healthcare professionals and advocates on health and disability insurance and finances. Again, more information and registration is available on our website. In addition to our events, we offer a number of online educational materials and resources. Our quick guides are designed to be a snapshot of a particular topic. They cover areas such as health insurance, employment, clinical trials, financial topics, estate planning, and legal assistance, and many more. You may order hard copies of these materials on our website. We also provide educational animated videos on cancer survivorship topics. We have this one on health insurance basics with key information that you need to know about your health insurance plan, especially to minimize your out-of-pocket costs. We also have a video on how to pick a health insurance plan, and more videos are being added. These videos are available in English and Spanish, and we are adding other languages via subtitles. We also have state-specific resources on our site, including on topics you will hear about today. And because where you live can impact the protections you have access to, we have charts of state laws on employment, disability, and health insurance related issues. Cancerfinances.org is a site that we host in partnership with the SAM Fund that provides practical information on topics that can impact your finances. We also provide contact information for financial assistance resources. We just released a new module on education, which covers education rights in school, accessing accommodations, and dealing with student loans. Our educational blog not only provides great information about cancer survivorship topics, but because things are constantly changing in the cancer community, this is how we share late-breaking news. We also have a monthly newsletter, which is where we announce all of our upcoming events. So we spent a bit of time talking about how Triage Cancer's various events and resources because we hope that today is not the end of your relationship with Triage Cancer and that our resources prove to be helpful to you. Now, before further ado, I'm delighted to introduce you to today's speakers, Joyce Reinecke and Monica Bryant. Joyce is the Executive Director of the Alliance for Fertility Preservation. Previously, she was a cancer and fertility advertiser for the Livestrong Foundation and Vice President of Programs for Fertile Hope. Joyce has spent her career advocating for the rights of others to preserve their fertility, and her own experience as a cancer survivor informs her professional focus and her commitment as a patient advocate. And Joyce will be speaking to that a bit more herself. Our other speaker today, Monica, is the Chief Operating Officer for Triage Cancer and a cancer rights attorney, speaker, and author dedicated to improving access to and availability of quality information on healthcare-related issues. Throughout her career, she has provided hundreds of educational seminars, written articles and blogs, and appeared on community television and radio shows discussing healthcare-related issues. With that, I will hand it over to Joyce.
Hi, thank you so much, Sarah. I just want to start by thanking Triage Cancer for their partnership on this webinar and for their interest in this specific topic of fertility preservation. And I want to thank everyone who has taken time out of their busy schedule today or summer vacation, as the case may be, to attend this webinar and really care about this topic. As Sarah mentioned, I really came to this work by way of my own personal experience. I was diagnosed with a rare form of cancer called leiomyosarcoma when I was 29 years old. And I really do count myself fortunate for having received good information at that time that my planned course of treatment, which was supposed to be surgery and then chemotherapy, would present a risk of infertility. And so that was really quite shocking. And during the initial stages of diagnosis, that wasn't mentioned, and it never occurred to me. So it wasn't anything that was a kind of a natural connection. I didn't have a gynecologic cancer. And so that's always played on my mind and shaped, the way that we talk about infertility and the risk of infertility and how it really spans almost all cancer types. So when I was informed that I might be at risk for infertility, my husband and I was married at the time, were able to take steps and get to a fertility clinic and do fertility preservation. So that is another point on which I feel really extremely lucky. And my experience now over the years in talking to patients and learning their stories is that is often not the case and hasn't been the case in the past. And I think hopefully we're moving to a time when those discussions and that information is shared on a more widespread basis so that people have time to make these choices before they start active treatment. We went through a cycle of IVF and we ended up freezing embryos, and that really shaped, my cancer experience. It was actually a really positive experience and really a very hopeful experience, and gave us opportunity to kind of shift focus a little bit at that really, really intense time and think about what our life might look like down the road and what having a family might be like. And so I found that overall to be a pretty positive experience for me. We ended up freezing embryos and then working with a surrogate, and we ended up having twin girls. So I feel really, really lucky in that entire process. This is not what they look like today. They just turned 18 and they're heading off to college, one starting in 2 weeks. So this has been a full circle journey for me. But it was this part of the cancer experience that really resonated with me and really had such a strong impact on my everyday life. And it really catalyzed me away from what I was doing professionally, which was working as a trademark attorney, into advocating for myself and eventually for other patients. So as Sarah mentioned, I started out working at an organization called Fertile Hope, which was really, I think, the very first nonprofit that was singularly focused on this issue of cancer-related infertility. And that was a really wonderful experience. And out of that experience, I then went on to work at the Livestrong Foundation, which took up some of this work and was really a tremendous partner for Fertile Hope. I am now at an organization called the Alliance for Fertility Preservation, and we are a nonprofit organization working across the country. And we are really focused on trying to increase information levels, resources, and also, particularly lately, we've been focused on the access piece of fertility preservation to get patients the services that they need. And also our goal is to provide information and resources for healthcare providers, especially in the oncology space, who want this information for their patients. So our goals are really, as I said, to provide tools and resources. We also are looking at ways that we can promote the adoption of more systematic approaches so that people don't fall through and don't, get into the position of not receiving this information or not receiving the referrals that they need to understand what their reproductive options are. We really advocate for more access, and we would like to see access expanded on a more equitable basis so that fertility preservation isn't an option only for people of certain socioeconomic means. We try to encourage dialogue and collaboration between clinicians, between oncology providers in particular and their patients, and also amongst providers, so between oncology providers and reproductive specialists. We achieve our goals through a variety of means. We speak at a lot of conferences and do sessions like this, webinars. We attend professional events, and we're always trying to elevate the level of dialogue around this issue. We also answer direct patient inquiries over the phone and through email when people are looking for services. We work with other nonprofit partners like Triage Cancer to advocate and increase information on the topic. We have lately been working with policymakers, such as legislators and insurance regulators, to try to provide content expertise on this subject for them so that they better understand some of the patient needs around coverage. We also provide patient stories through our website and try to engage with individual patients to facilitate them sharing their experience with policymakers and publicly through social media, through testimony, and at patient-focused events. One of our primary tools is called Fertility Scout, and that's on our website, and that is an online HIPAA-compliant referral tool, and that is meant to facilitate referrals so that patients can get fertility services very quickly. So if we step back and start talking about what fertility preservation is, what the issue is, fertility preservation is really about the process of saving eggs or sperm and taking them basically outside of the body and shielding them from the damaging effects of some cancer treatments like chemotherapy, radiation, bone marrow transplants, so that they can be stored and used by the patient in the future. And when we're talking about fertility preservation as an organization, we are really confining ourselves to a discussion of what we call iatrogenic infertility. And the reason it's kind of laid out this way for you here to pronounce it is because it's kind of difficult. But iatrogenic means that it's essentially a side effect. It's something that is caused by a medical intervention. And that's the kind of infertility that we're focused on. So iatrogenic infertility then in short means that it's a type of infertility, a subtype of infertility that is really caused by a needed medical treatment that a patient has to undergo. So when we're talking about who would need this kind of intervention, who needs fertility preservation, I think it's important to recognize, as I said at the top of this discussion, almost all cancer patients are at risk because the risk generally is tied to treatment and not necessarily the cancer itself. So this means that every year in the US, there are approximately 1.5 million patients diagnosed with cancer, and about 10% of those are what we call reproductive age patients. So that means they're 45 years old or under. So almost all of them face some level of risk. Obviously, their amount of risk is going to be determined by their particular treatment, by the type of chemotherapy they have, or where radiation is directed. But because treatment can change quickly, patients need to know, about this risk up front. So in addition to cancer patients, which is our primary focus as an organization, we have seen that there are other patient groups and other populations of people who are looking for fertility preservation services. Some of those populations are people with other diseases, such as certain autoimmune diseases. Sickle cell is an emerging population because the treatment of sickle cell now, one of the treatments is a bone marrow transplant. So those patients are definitely at risk and would need preservation before that treatment. And there are people who are looking to undergo fertility preservation, if they wanted to screen for certain genetic cancers like BRCA, where they might have to take steps to reduce their risk of developing cancer, such as having their ovaries removed before they're necessarily ready to have children. So this sort of speeds the timeline for them. Most recently, we've had a lot of dialogue with experts and with patient care providers around transgender patients' needs and where fertility preservation is available to them, whether that's covered or not. So that's a really new kind of consideration. In terms of the options for fertility preservation, there are what we refer to as standard options, and there are also experimental options that are on the horizon and being sort of developed all the time. So for men, we always say, it's much easier, frankly, for women than for women to preserve their gametes or their sperm. So typically men can sperm bank as long as they are, have entered puberty. If they are in the pediatric population, there are only experimental means that are available to them, such as testicular tissue banking. So in addition to sperm banking as a standard technology, sometimes if patients are ill, when they present, they may need to undergo some kind of medical interventions to help them with the sperm banking process, but those are also available and should be thought about. For women, women typically for fertility preservation would go through kind of a standard process, just like if somebody was seeking infertility treatment. So they go through an egg freezing process, which is very similar to standard IVF in that they have to go through ovulation induction, which means that they take medications to develop and mature eggs within their ovaries and have those then removed. If you're doing egg freezing, you would freeze the eggs at that point once they're matured. If you're doing embryo freezing, that means that the eggs that are removed have to first be fertilized either with a husband or a partner sperm and then frozen. So that's the difference between those processes. There are also experimental options such as ovarian tissue freezing, which would be available for women who are pre-pubertal, pediatric patients, but also post-pubertal. And that is sometimes a technique that is sought if a patient really doesn't have enough time to undergo a cycle of egg or embryo freezing. So a normal cycle, a standard cycle of egg or embryo freezing, even if it's done on an emergency basis, is going to take at a minimum, probably 10 days to 2 weeks. So what we've seen over the past few years is really an increased demand for fertility preservation. And we have thought about this quite a bit and to try to understand why this may be happening, we've sort of created these buckets of factors that are pushing this. I would say some of the really good news about this is that improved cancer survival rates are driving some of this. That is coupled with delayed childbearing. So in the US, I believe now the average age for a first conception is over 25. So what we're seeing is you may have patients who are diagnosed, let's say in their 30s with breast cancer, and perhaps a generation ago, these patients would have already had or completed their family building. Now it's much more common to see women in their 30s who have not had children yet, and if they are diagnosed, this is something that they're concerned about. Also, I would say that on the good news front, the reproductive technology has changed vastly, even in the time that I have been working in this space. So for example, the American Society for Reproductive Medicine in 2012 recognized egg freezing as being standard technology. So that opened up a whole new option for patients who didn't necessarily have a partner or weren't eligible or interested in doing embryo freezing. So year over year, these techniques have become more effective. And as I said, there are more techniques coming on board and being studied all the time, such as tissue freezing, that are going to give patients more and more options. I would say coupled with the improved cancer survival rates that we're seeing nowadays, that has also driven some of the dialogue around survivorship and really looking at what the long-term quality of life will be for cancer survivors. So I think there used to be, again, probably a generation ago, a perception that cancer really, in many cases was a death sentence, and there wasn't a focus on looking at the impact of cancer for the patient long term and what their life would be after that. And now we have the luxury of looking at that. Sorry, one sec. Okay. In terms of what exists now as the barriers to fertility preservation, I mean, you may be asking, what's the problem? I mean, if these technologies are effective, they're available, patients are increasingly learning about them, you know, why are we having to have these kinds of discussions and trainings? And I would say that although there's better disclosure and there are, you know, now professional guidelines that address having these kinds of discussions with patients at the time that they're diagnosed, there is still not kind of a universal attention to this issue. And so we're pressing against that and trying to increase that. Sometimes the referrals and the discussions are just not had in time for the patient to access these options, which really have to be, you know, have to be occurring on an emergency, really short time frame basis. And I would say there's also some lack of decision-making support around this issue. And there are some studies that have shown that, you know, depending on how the oncology providers frame these discussions or present these discussions, and whether or not the patients feel they have kind of permission to do this and to deviate in their focus away from, you know, just being focused on cancer treatment to think about family building. I would say the primary barrier, and this has been identified also in the literature, is access. And the most significant barrier to access is the financial piece of this. So typically these procedures for fertility preservation are high cost, and there is also a general lack of insurance coverage. So it can be really prohibitive for patients, especially who have this very small time horizon to access these services, to come up with the money needed to access. There are some other access issues that have to do with just geographic availability of services. So, for instance, the most you know, state-of-the-art egg freezing techniques known as vitrification, that isn't always available. So some states don't even have fertility clinics. So there can be some logistical problems with getting patients the services that they need in time, even if they could afford it. And then there are just general, I think, cultural prohibitions around this issue and a lack of discussion about reproductive technology and reproductive options in general. So in terms of understanding what the costs are exactly, this is just a chart from our website and based on information that we've gathered. You can see that the costs, especially for women, can be very, very high. So if you have a young adult patient who has an out of the blue, you know, cancer diagnosis and only has a matter of days in which to come up with, you know, $10,000 or $15,000 to do egg freezing, it can be a real problem. And patients who really care about the services and would like to access the services can't always actually, in a practical sense, make that happen. This is just one of the other wrinkles of coverage that I wanted to bring to your attention. And this is just an example to show you that even where patients may have fertility coverage, meaning a plan that includes IVF, they may not be able to access it as a cancer patient with a new cancer diagnosis because they are not technically infertile. So this is just a quote that you can read. This was from a final denial. So it was like a second or third level appeal that was denied. And this was issued and written by a medical doctor. And there is, you know, a lot of contradiction, obviously, within this statement. The patient had coverage and would have had access to egg freezing if she had the diagnosis of infertility. But ironically, she would only be able to access her benefit after she was left infertile by her cancer treatment. So just to let you all know, this was actually appealed externally through the Department of Insurance in the state of Illinois, and the patient actually got a reversal of this decision. So that was a really great victory, and the plan had to ultimately reimburse her for the egg freezing that she went through. But this result that you see on the screen is more typical.
So if an individual does get a denial of services from their health insurance company, they're likely going to want to take some steps to fight that. And the first part of the process is to make sure that they understand their insurance company's rules. And that starts with understanding the fact that most insurance plans have a network of providers. And these are doctors and hospitals that have contracted with the insurance company to provide services. So the first step is to really even understand what their policy says and what their network is. Now, some plans will require that before you even try to get any of these services, you get a pre-authorization for them to provide coverage, which means before you've even walked in the door to do egg freezing, you have to go to your insurance company and ask if they're going to cover it. More often than not, they're going to come back and say, no, we're not going to cover that in their pre-authorization. You may be able to ask for an exception request, which is where you ask your insurance company to make an exception and cover the particular service because it's medically necessary. But bottom line is you have to be proactive about all of this and ask questions. So we hear story after story after story where even if there is a discussion about potential infertility due to cancer treatment, the healthcare provider goes and checks that patient's insurance policy, comes back and says, oh, they're not going to cover it, so we're just going to move forward with whatever your cancer treatment's going to be. And so really, we want to make sure that patients stop at that point and continue to ask some questions. So did the healthcare provider just call and get a verbal denial from the insurance company, or did they actually submit the pre-authorization and get a written denial? And the reason that that's important is because those details are going to matter in terms of your ability to appeal the decision. And Joyce and I have both said the word appeal a couple of different times, but what does it actually mean? As consumers of health insurance, we have the right to appeal if our insurance company denies our claim. And there's two different types of appeal. There's an internal appeals process and an external appeals process. The details for internal appeals processes are going to vary based on the company, so it's really important to check the policy. You should get information in that written denial, but all of that can take time, and as Joyce mentioned, individuals in this situation may not always have time. Now, thanks to the ACA, all states are also required to have an external medical process. This is sometimes referred to as independent medical review, or IMR. For more details on your state's external medical review process, you can certainly contact your state's insurance agency. At Triage Cancer, we've also compiled all of that contact information on the state resources page, so you don't have to try to figure out where to go. But the good news in all of this is that the chances of getting your claim covered definitely increase if you appeal. One study that was done a few years ago now showed that somewhere between 39 to 59% of all the appeals were decided in the favor of the patient. So it's really in their best interest to think about appealing. And this is just a very simple illustration of how the appeals process works. Not all of them are this straightforward, and sometimes, especially in instances of fertility preservation, people have to go down these paths at the same time. But starting at the top, treatment is received or a prior authorization has been filed. Once the claim is filed, either by your healthcare provider or by you do it yourself, two things can happen. On the left-hand side, you can see the insurance company approves the claim, they pay their portion, the doctor sends you a bill, you pay the remaining balance. So that's best case scenario. it happens quite infrequently in the case of fertility preservation. More often, we're going to end up on the right side of this diagram, where the insurance company is going to deny the claim. The patient then files the internal appeal. If they win the internal appeal, we're back over to the left side, the insurance company pays their portion, you pay your portion. If you lose that internal appeal, then the next step is to file an external appeal or that independent medical review. And these decisions are supposed to be binding on both the insurance company and the patient. So if the patient still loses the external medical review, then the patient has to figure out some other way to pay for the treatment. But if they win the external medical review, then the insurance company is theoretically required to pay for those services. So now that you have sort of a broader overview of how an appeal is supposed to work, it's important to understand the steps. And one of the most important things I think for patients to keep in mind is the idea that this is not something that they can do on their own. This has to be a team effort with their healthcare providers, and they're going to more than likely have to be the ones pushing this forward. If you haven't gotten all the information about why the claim was denied, that's step one. Understand why the claim was denied, get the full plan benefits language, and understand the internal appeals process. When you're going through all of this, obviously it's a high stress time for patients. They've probably just been diagnosed with cancer treatment. They're thinking about their future families. How are they going to pay for all of this? So it's critical that they not rely on their memories to keep track of all of this. We have a very simple appeals tracking form on our website at triagecancer.org that you can download, and it's just a way to organize the information. And it's also a really good time to delegate to friends and family. So often we hear, let me know if there's anything I can do. And patients are at a blank. Well, what can my friend do? Well, your friend can be on the phone with you and be writing all this stuff down for you when you're talking to the insurance company. Now, the next step in all of this is to make sure that the patient understands why the claim was denied. More often than not, in the instance of fertility preservation, the denial is going to be that you're not eligible for the benefit requested under the health plan. So Joyce showed an example that yes, you have fertility, or yes, you have fertility coverage, but you don't technically fall under the definition of being infertile yet. So it could fall under different things, but more often than not, that's going to be the reason in the fertility preservation context. So the next step is to get some support from your healthcare providers. And this is going to be anything that helps you prove that there are medical reasons that you need the fertility preservation. And I'm sure Joyce has a plethora of information to send to people. But here you're talking about letters from your healthcare providers, the results of tests, any current literature that shows that the course of treatment that you are going to undergo more likely than not is going to result in iatrogenic infertility. And then it can also be helpful to include a personal narrative describing the need for the fertility service. Now, there's some timing involved in all of this as well. So if somebody has requested a pre-authorization or a prior authorization for coverage and it's denied, they can then submit an appeal. And the specific time period for when that has to happen should be listed on the letter, and you should get a decision within 30 days. But as we've talked about, there's often a urgency with fertility preservation because you don't want to delay the cancer treatment any longer than is absolutely necessary. So in those cases, it may be that you need to ask for an expedited appeal, and that's where the insurance company is required to give a response within 72 hours of receiving that appeal. And there's some rules around all of this. But if your healthcare provider can show that the delay in treatment is going to seriously jeopardize your overall health or your ability to regain maximum function, then an urgent or expedited appeal is appropriate. Now, if somebody goes through the internal appeals process and still the insurance company denies the claim, then they can go get an external medical appeal, also known as independent medical review. And every state has this external appeals process, and there's 2 steps in all of this. So you file the external appeal, which is a written appeal, and again, in the case of fertility preservation, it could be that you get the answer within 72 hours. And in some instances, you may actually be able to file the internal appeals process at the same time as the external appeals process. And the reason you can do that is because of the expedited nature for this. Now, I also just want to mention we're broadly talking about health insurance policies all as being one thing, but the rules are slightly different if you receive your health insurance policy through an employer, because that plan is going to be governed by a law called ERISA. And we certainly don't have enough time to get into ERISA today, but just know that there's going to be a slightly different procedure for those plans, but the basic steps that we've outlined today are still going to apply. Now, when we talk about paying for fertility preservation, the second piece to this is direct financial assistance. And someone may have to seek out financial assistance to pay for the costs that Joyce outlined, even if they are trying to appeal the insurance company's decision. Because it may be that fertility preservation has to happen immediately, and you don't even have the 72 hours to wait for a health insurance company's decision. So you may have to pony up that money first, even before you get a decision from the health insurance company. But then there may also be some additional costs that an insurance company, even if your claim is approved, isn't going to cover. So Joyce talked just about sort of the first step of fertility preservation costs. But then even if somebody banks their sperm, there's going to be ongoing storage fees that you may have to pay for. And then certainly there are going to be some costs after cancer treatment has been completed when that individual is ready to move forward with their family building. So financial assistance may still be necessary. So on cancerfinances.org, which Sarah mentioned earlier, today we have a whole section on financial assistance resources, but then also the Alliance for Fertility Preservation has a phenomenal page that outlines all of the different programs that are available to help individuals pay for the preservation side, as well as to pay for the post-treatment side as well. Now, if any of you have ever heard me talk before, you know that I can't get through a presentation without talking about advocacy. And here certainly is a prime place for an advocacy plug. And we call this triangle the spectrum of advocacy. And some of you may want to touch each tier of the spectrum. Some of you may only be interested in 1 or 2 areas of this. But I did just want to mention, as we're going to get into a short discussion about legislative advocacy around fertility preservation, that I just did a 1-hour-long webinar on legislative advocacy that is archived on the Triage Cancer website.
Yes, thank you, Monica. I just wanted to say that we were talking about the direct appeals process and how individual patients can maybe change their coverage situation. Monica just referenced the numerous ways that you can be an advocate. One of those areas is legislation that we're going to talk about next. I just always like people to understand that when we're talking about advocacy as an organization, we are talking about advocacy in a broad sense as well. And so there are numerous ways that we have seen pressure being brought to bear on this coverage issue for fertility preservation. And so some of those are outlined here. There are private approaches to getting coverage, such as meeting with insurers or your own employer and asking for this. We have seen patient groups, nonprofits across the country calling for this kind of coverage. One of the most important factors, I think, driving the need for coverage and driving this discussion about whether coverage is something that should be required is coming from the professional organizations, ASCO in particular, ASRM, but even other medical groups that are in the reproductive and cancer spaces, putting together guidelines and really outlining fertility preservation as part of the standard of care for these patients. That is really putting pressure on the insurers. There have been numerous research studies, there have been articles that directly call for this coverage and outline the bases for coverage. There have been attempts for administrative change, and I will say personally as an organization, we've been very actively involved in working with the Department of Managed Healthcare in California to try to get some regulatory change around this and make sure that the coverage is in place and being actually implemented for the patients who should have this coverage. And then what we're going to get into now is kind of the legislative actions that have been occurring over the past, I'd say, 1.5 to 2 years that are driving some of this change.
And those legislative actions are a result of legislative advocacy. And when we talk about legislative advocacy, specifically, we're talking about working to achieve a legislative outcome. And that could mean getting a member of Congress to introduce a bill, like we're going to require the insurance companies to cover fertility preservation even without a definition of infertility. It could mean resolutions expressing the need for fertility coverage. So it really can be broad, but ultimately most of the advancements that we've seen in the cancer community have started with legislative advocacy. And I certainly think that this is an area that is prime for us to get involved. And so I'll let Joyce talk a little bit more about the specifics of how legislatively we can make some changes and make fertility preservation more available for individuals who've been diagnosed with cancer.
So one of the first things that we've looked at in the past, as I would say, 2 years, is where this coverage should live. So there have been a variety of approaches that have been advocated. So one place that this fertility preservation insurance coverage could be included would be by amending existing infertility coverage so that it is more broad and it includes this situation. And that is really the case that we've been seeing in the bills that have passed recently. So 4 states in the past 2 years have added fertility preservation coverage, and all of those have or had, I should say, one, Delaware actually enacted together infertility coverage with fertility preservation all at once. But all of the states right now that have passed mandatory fertility preservation coverage legislation also have infertility coverage. And another way that that can be added is if you have self-insured companies or employers who offer infertility benefits, is to make sure that the language of those benefits is structured in such a way that fertility preservation can be added to that. The other approach would be looking at fertility preservation more as just a standard part of cancer care and including or mandating coverage on that basis, that this is part of the comprehensive package that of benefits that someone who diagnosed with cancer would have. And so when we talk about that approach, the most kind of parallel situation is something called the Women's Health and Cancer Rights Act. And this actually amended ERISA, which Monica touched upon, which is federal legislation that covers self-insured plans. And what this legislation did is it said any insurer who is offering mastectomy coverage also needs to include coverage for reconstructive surgery. And that they just deemed reconstructive surgery medically necessary and a comprehensive part of cancer care. And so I think this is a really good model, especially to look at for states or plans that don't have existing IVF coverage. You don't have to build fertility preservation coverage necessarily on top of existing fertility coverage. It can be linked more to the underlying medical condition that is causing the need for fertility preservation, such as cancer care. So as I mentioned, there have been 4 states that have enacted fertility preservation legislation in 2017 and 2018. So Rhode Island is one of those states. I have highlighted it here just to give you an example of this language and how broad it is. This language talks about including standard fertility preservation when it is medically necessary, and you see the iatrogenic infertility language there. That I think is pretty clear and hopefully would cover patients who, in addition to cancer patients, who have a medical need for this type of service, for fertility preservation. So that was the second state to enact. This is just a map that gives you a sense of what's going on across the country. There were, I believe, in 2018, 15 states that looked at some legislation that either was standalone fertility preservation legislation or was was wrapped into a call for IVF coverage generally. So we still have a few states that are pending right now for sessions that have not gone out, including Illinois and New Jersey, and we're very hopeful that those states will go forward and fertility preservation will be enacted there, bringing the total of states that have this coverage by law to 6.
So with 15 states currently looking at legislation, that's certainly great news. It's better than none, but it's still not great in our opinion. And so if you are just one person sitting in front of your computer listening to this, how do you get involved? I recognize that for a lot of people, the idea of legislative advocacy is overwhelming, but I don't think it needs to be complicated to have a big impact. So you can certainly be an advocate on your own. We have resources on the Triage Cancer website. Send emails to your friends and family, engage with your elected officials. Joyce talked earlier. Joyce was talking earlier about sharing your story. If you have decided to disclose publicly and have thought through all those ramifications, sharing your story is a wonderful way to be an advocate. Certainly joining an organization's advocacy efforts is useful. The Alliance for Fertility Preservation has a great page on their website about getting involved, and we've given you the link here. But certainly I think the simplest way you can get involved is to vote. If you are passionate about this issue, make sure that you've talked with your elected officials about how they feel about this issue, because we have such a privilege in this country to be able to vote and have a say who our elected officials are. And as an example of where the types of advocacy can overlap, social media has become a really wonderful tool to engage with your elected officials. And this is just an example, not related to fertility preservation, but you can see how there was a whole conversation started by one tweet that just continued on, and it was quite interesting to watch in real time. And if you're interested in more about social media and advocacy, we have a webinar archived on our website specifically about how to use Twitter, but Facebook is also a really useful tool. So with that, we have a few minutes left where we can take questions. So please go ahead and type your questions into the chat box on the side of your screen. And while we're waiting for some questions to pop in, we just wanted to provide you with various ways where you can continue to have a relationship with both Triage Cancer and the Alliance for Fertility Preservation. We are constantly, both organizations are constantly putting out some great stuff, and we're on social media, so we hope you will consider continuing to connect with us. So we have some great questions coming in. So the first one for you, Joyce, is if I wanted to go through the appeals process, are there any templates or examples that I can use as a starting point?
Yes, we do have appeal letter templates that are available on our website and that I can send to anyone individually for customization. And we also have examples. As I said, we've been working with the system for the Department of Managed Healthcare out here in California, and they have a really great public-facing IMR, website and portal. And so I have extracted those IMRs that are relevant to fertility preservation. So I have them in a document that I can send, or I can link anyone right to that. And you can do searches on fertility preservation, and you can see some of the great outcomes that have been published. And so I think looking at those IMR decisions, and Monica talked about this before, understanding the why of your denial and also the why of positive decisions, I think is really helpful in structuring your own appeal. So if you can use that language, cite to the authorities that the decision makers find influential and important, such as the ASCO guidelines. I think seeing those IMRs and the bases of those positive outcomes is really helpful in writing your own appeal.
I think that that's absolutely correct. Why reinvent the wheel if you don't have to? So what's the best way for them to connect with you, Joyce, if they'd like to see those documents?
You can email me directly, Joyce at Alliance for Fertility Preservation, or advocacy at Alliance for Fertility Preservation, and we have those resources available, and I can discuss those resources or how to use them, at any time.
Fantastic. So we have another question from a healthcare provider about if the oncologists aren't having conversations with newly diagnosed patients, how can we as support staff make that a more regular practice? Do you have any thoughts on that, Joyce?
Well, that's tricky. It's dicey who has the authority, to introduce these conversations. I know that there's some, kind of political issues there. I would just say that when we have given presentations or rounds presentations, we tread lightly on this, but do always try to call attention to the oncologists, to the ASCO guidelines and say, this is your own professional organization. This is the guidance that they give. This is really the standard of care. And so we definitely think that may be helpful if you can point the providers, to those authorities. There are also a lot of studies that show that this really does impact patients' long-term quality of life, that patients who have unresolved infertility from cancer treatment do have higher levels of depression, report lower quality of life. So I think sometimes if a provider is being a little bit dismissive about, the need for these discussions, I think that those are important points that maybe you can make privately, with the oncologist.
Fantastic. Thank you so much, Joyce. I really appreciate your expertise on this topic. So with that, I'm actually going to pass it back over to Sarah to wrap up.
Okay, thank you, everyone. That's all we have time for today. If you would like more information about this topic or would like to stay in touch with Triage Cancer, you can email us at info@triagecancer.org. You can sign up for our newsletter on our homepage at triagecancer.org. You can connect with us on social media, including Facebook, Twitter, and Instagram, or on our blog at triagecancer.org/blog. Now, again, to go over this again, in order to receive contact hours, you must have registered online for today's session. People who are listening in on someone else's computer are not eligible for credit. You must also have attended the entire webinar. No partial credit will be awarded. Anyone watching a recording of this webinar will also not be eligible for credit. Within 1 week of this webinar, complete the evaluation and post-test. You must receive a passing grade on the post-test to be eligible for contact hours. You will receive an email following this webinar, which will contain the link to the evaluation and post-test. Please note that on the evaluation, it asks for your name and email address, and you must include these so that we can certify that you completed the evaluation. That email is the address that we will use to mail your certificates. We'll be sending those out within 4 to 6 weeks. Again, we only are able to offer contact hours for nurses at this point. If you have any questions, please email us at info@triagecancer.org. This concludes today's webinar. Thank you.